Right. All right. So welcome everybody to Psychology Grand Rounds, our June 2024 edition. Today we are going to be hearing from Dr. Nechama Sorscher, who's going to talk to us about assessment and intervention with patients with neurocognitive challenges from a psychodynamic perspective. A little bit about Dr. Sorscher. She's a clinical psychologist in private practice here in the city. She teaches neuropsychological assessment at the William Alanson White Institute, and she's a graduate of the doctoral program at Adelphi, and did her fellowship at NYU in psychotherapy and psychoanalysis. She is really quite accomplished. She has published books and book chapters and articles really on a range of diverse topics, including working with patients with neurocognitive challenges, transgenerational trauma, and the impact of COVID. We're really lucky to have her talk to our group today. And before we turn the presentation over to Dr. Sorscher, I think everyone knows by now the CE link for psychology is going to be posted to the chat. And this is actually our last grand rounds of the academic year. So we're going to take a little bit of a hiatus for July and for August, and then we will be back in September. So sometime in in August, be on the lookout for the email regarding the information for our September talk. All right, so Dr. Sorscher, if we can spotlight you, we will get you started. Thank you so much for talking to our group here.
Thank you. I'm just going to share my screen. Okay, I think that should do it. Okay, is that good?
Yes.
Okay, perfect. So, as Christina mentioned, I'm going to be talking about patients with neurocognitive challenges. And these are people that we see quite often come into our offices. I'm going to say that when I'm talking about these patients, they can be very young or they can be very old. These disorders are diagnosed typically in childhood, but actually some people go all the way to retirement before they realize that they have challenges. So whether a 5-year-old comes into your office or a 75-year-old, it's really good to keep these challenges in mind and see if your patient meets criteria for any of them and how you can help them. An increasing number of people do identify as neurodivergent, and they'll come into my office, and I'm sure into your offices, and say, hey, Dr. Sorscher, I think I have ADD, or I think I have autism, and sometimes they do, and sometimes they don't. So it's really important for us to be on the lookout and be well-versed in these particular challenges. Very often, people with these challenges have a lot of psychiatric issues. So people might come in and say they're depressed, or they have low self-esteem, or they're anxious, but the etiology is the neurocognitive challenge. Very often, these challenges also present as either academic, professional, social, or interpersonal problems. So we, again, want to be on the lookout for that. This is pretty much of an under-researched, overlooked area, and especially in terms of analytic treatment. I'm going to talk a little more about that, and I'm going to combine psychoanalytic theory, developmental perspectives, and neurobiology. So there are a lot of this around in terms of some statistics. 20% of all Americans suffer some form of neurocognitive issues. This is likely an underestimate because this is an often misdiagnosed or underdiagnosed issue. 5 to 10% have some form of learning disorder, 3% have ADD, and 2% have ASD. As I mentioned before, there is a significant neurobiological influence on learning disorders. Now, this is really important to know also because patients very often will blame themselves. So one of the most important pieces of work that I do with my patients, and I have to do this a lot with them, is educating them and explaining to them that no, they're not lazy or bad or stupid or have some kind of moral character dysfunction, but in fact they have some kind of hardwiring in their brain that predisposes them to be vulnerable to some of these issues. We found differences in people's brains when they had learning disabilities on a post-mortem basis. When they did studies with dyslexic children and they looked at what areas of the brain light up on a PET or an MRI. The areas in the brain that light up when a typical child is reading is very different than when a diverse child is reading, which is very, very interesting. And I think there's going to be a lot more research on that. People who have nonverbal learning disorders, which I will talk about, have disordered functioning of the right hemisphere, and the right hemisphere processes visual spatial information. So it's highly related. The people with the language-based learning disorders have reduced access to the left hemisphere. The left hemisphere is in charge of language. The right hemisphere is in charge of visual spatial. It's been very well documented that individuals with ADHD have reduced functioning of the prefrontal cortex. In fact, my son who has ADD is always telling me that he doesn't have any prefrontal cortex, which is kind of funny. The prefrontal cortex meditates impulse control, planning, and organization. So it is a very important piece of your brain. Autism is interesting because autism is not related to any specific area of dysfunction, but is widely distributed. And that makes sense because autism is much more of a global impairment where people have very significant areas of deficit on a pretty much of a lower level of functioning. So let's say somebody with dyslexia, they have a very specific area of dysfunction and really they only have trouble reading, they don't have trouble with many other things. But people with autism have trouble with socializing, with their feelings, with some types of thinking that we'll go into, and they have shown that there's disruptions in the neural pathways, which makes sense given the symptoms. There's also a big influence of genetics. So very often when I test somebody, they'll tell me, their aunt had something similar, the father had something similar, the cousins all are similar. So family studies have shown a huge genetic contribution, both to attention and to learning, and actually also to autism. If people are exposed to toxins when they're in utero or in childhood, that can also be a contributing factor. Lower birth weight is associated with learning disorders. In fact, preemies are at risk for a lot of learning and attention problems. And also the interpersonal environment, particularly during infancy and toddlerhood, has a significant impact. And when kids are neglected or they're understimulated, that can really impact their IQ, their academic skills, their ability to process information, and so on. Okay. I'm just going to show a picture of the brain and kind of point out which of the lobes are really impacted. So here is the frontal lobe, and that, as I said, was responsible for organization. You think about it like the front of the brain, the part of the brain that really is giving everybody else the information, almost like the secretary of the brain. Then you have the temporal lobe, which is responsible for memory and some language skills. You have the limbic lobe, which is responsible for emotions. You have the occipital lobe, which is responsible for visual processing and visual images, and the parietal lobe, which is responsible for sensory stuff. I think what's also interesting to note is how closely the lobes are, and also in particular the limbic lobe, which is the feelings part, which is what we deal with the most, how much that is influenced by the other lobes. So when somebody comes in, they tell you, let's say that they have frontal lobe issues, they probably also have emotional regulation issues, for example. Okay, I'm going to start talking about ADD or ADHD. Now, right now, we don't make a differentiation between ADD and ADHD. We used to, but we don't anymore. We think about all these disorders as a spectrum. And it could be mild, all the way up to really, really significant, and anything in between. So that's important because sometimes people can miss these challenges because they are subtle. But when you look at it and you really put together the whole picture, it's not so subtle. So ADHD is the big group, and then there are two subgroups. There's inattentive and hyperactive. So inattentive people with ADD present as kind of spacey, daydreamy. The typical example is the absent-minded professor. Can't find his glasses, his keys, his papers, and so on. The hyperactive type is more rambunctious and boisterous, and they're often the life of the party and very, very social, but can be kind of inappropriate. Both types suffer from executive functioning disorder. That's a big buzzword that you're going to hear a lot. So it's important to kind of be hip into it. And basically it means that they have difficulty planning, organizing, and I put up a little picture of a very messy, disorganized person over here. I think it's Pigpen. And poor Pigpen is always running around in a cloud of chaos. And that really is, even the inattentive spacey type runs around in a cloud of chaos because they're always forgetting things. And they're late. And they underestimate how long does it take them to do something, and so on and so forth. I'm going to give you a case example. So this is the patient I'm on, his name is Eric. He had undiagnosed ADD. I met him when he was 17. He was struggling in high school, despite being very intelligent and verbally sophisticated. He described himself as a class clown and said that he learned to get attention from his peers for being funny and being disruptive in the class, and he would tell me these funny stories, but the stories always ended with him getting into a lot of trouble. And part of what we do psychoanalytically is we really dig into those experiences. What did it feel like to be always getting into trouble? Yeah, it felt good when the kids laughed, but what about the next minute? And what about afterwards when you went home and your mother beat you up? Those feelings of shame, they last a lifetime. So when I met him, because he was berated and because he was known as to be a troubled person, and because he never submitted his assignments in time, he was significantly depressed. When we correctly diagnosed him and started treatment, his depression lifted, and he even began to see himself as successful, which took a while. Sometimes you really need to hammer this home, but you see he comes in saying, I'm lazy, I'm depressed, I'm unmotivated. It takes a while to explain to everybody, oh, there's ADD here, so on and so forth, and also to dig into those feelings of course you thought you were a failure. Everybody in your life was telling you that, but you really aren't. I'm going to go into ASD, or autism spectrum disorder, and again, I want to highlight that this is a spectrum. So some people with ASD can seem to be very high functioning, and obviously some people are very low functioning, but they all have ASD. The big hallmark is poor social skills and difficulty with feelings. And they often will very much live in their own world. And that's why I have Snoopy over here with the Red Baron, because Snoopy really believes that he's the Red Baron, right? And he's not the Red Baron, he's the pilot, and he's taking on the Red Baron. But he really believes in this, and he can happily spend hours in this world. And one of the characteristics of people with autism is they're very happy being by themselves and spending the time, with their imagination or with whatever activities spark their interest. They also can be extremely rigid. They have obsessive areas of interest. They have stimming behaviors. Now, stimming behaviors are kind of obsessive, self-soothing behaviors. It could be flapping, but also can be many other things. And they have difficulty with transitions. As I mentioned before, they have cortical and subcortical impairments in a deep way. So they have really global impairments. Quite often they're very detail-oriented, and they can focus on tasks that other people find boring. I have quite a few patients on the spectrum who are coders, and they are fantastic computer coders, and they're happy to sit hours in front of the screen and just figure out computer problems. It's very soothing for them. Often they also develop a passion area of interest where they gather incredible expertise. And a good example for this is Greta Thunberg, and we'll talk about this a little bit later, but they can both have an area of passion, and then they'll know everything about that area. I'm going to present a patient of mine whose name is Julia. She is one of those who's incredibly gifted computer programmer. She has significant social anxiety. She knows she can't read people well, and it takes her a long time to feel comfortable with people. She sets aside time for stimming behaviors, and she counts, let's say, stroking her pet is a cat, going under a weighted blanket, and she's very mindful that she needs that time to regulate. She does like to be social, but then she wants to be alone, and she is very easily overwhelmed by stimuli, and we'll talk about that some more. But one other characteristic is that they are very sensitive to stimuli and can be extremely distracted and overwhelmed by noise, by light, by odor. And she's an incredibly picky eater, and part of that is because of the being overwhelmed by stimulus. And before everybody understood that she was neurodivergent, her parents just thought she was a brat. and that she didn't want to try new foods, and she didn't want to participate in family gatherings. And we had to do a lot of education to explain that she did want to do all those things, but she was feeling very overloaded by the smells, the texture, the chaos, and that she needed to do it kind of on her own time in her own way. Now I'm going to talk about language-based learning disorders. What's important to know about language-based learning disorders is that there's an expressive part and a receptive part. So receptively, which is a much more difficult disorder to treat, the people do not understand conversation or directions. So basically, you can think about it as garbage in, garbage out, in the sense that they don't know what's going on because they can't really process the auditory information that's coming at them, and it's hard to treat because of that. Expressively, it's a much easier disorder to treat because they understand everything, they have good comprehension, but they can't express them. They can't express themselves well. And a subgroup of these language-based learning disorders is dyslexia and also difficulty with written expression. And I have this picture of this girl, and you can see why, because reading and writing have to do with words. So even though dyslexia originally is a visually based learning disorder because they have a hard time processing the visual information of the letters, it quickly becomes a language-based learning disorder because they have a hard time with the words. I'm going to give an example of a patient of mine named Max, who's getting a graduate degree in health science. He's extremely sweet. He's very thoughtful, but he struggles both academically and socially because he has an expressive language disorder. Although he has some friends, he has trouble communicating with them and often withholds information. So he seems reserved and shy and kind of snobby, but in fact, he just has a hard time expressing himself. Academically, he has a good grasp of the topics, but he often falls behind in the reading, or he's not able to submit written assignments on time because it takes him really long to complete them. When we met, Max was extremely anxious and depressed, particularly about his academic work. In fact, he did something interesting, kind of like Willie Loman, where he pretended that he was going to school and he pretended that he was doing his work, but instead he actually spent hours of the day just sitting outside on a park bench. And then when I finally caught up with him, and he was lying to everybody about it, that's when he came into treatment with me. I diagnosed him with a language-based learning disorder. He learned to open up to his friends and explain that it takes him a while to get his thoughts out. He began working with a tutor to help him with his papers, and he was able to complete his semester successfully. So understanding what's going on, again, is really very, very key. This is a guy who, people said, oh, you're anxious. You can't get your thoughts out because you're anxious. But he couldn't get his thoughts out because of his language issues. He would stutter. His words would come out all jumbled. So it was pretty obvious that that was the issue. Now, nonverbal learning disorder is an interesting disability. It's not in the DSM, by the way, but I'm a big believer in it. So the DSM, you put it under learning disorder NOS. Basically, it's when people have a discrepancy between their verbal skills and their visual spatial skills. And they have very high verbal skills, they have a very good vocabulary, they're often wordsmiths, meaning like not only do they have a good vocabulary, but this opposite of the language-based learning disorder, they can express themselves beautifully. These are the people who are just hyper-articulate and can, talk about very complex topics. But their visual spatial skills are really poor. They have difficulty with visual subjects such as math and science, and they also have difficulty picking up on social cues. So they have difficulty with facial expressions and body language, and even spatial concepts such as hierarchy. So I had a kid that I was treating, and she was always getting in trouble because they said she was obnoxious, and really it's that she didn't understand the difference between the teachers and the peers. So she would talk to her teachers as if they were peers, and the teachers would feel like she was being very disrespectful, and we had to explain it over and over again, kind of what the hierarchy was about. I will use myself as an example because I have a nonverbal learning disorder. As a teenager, I excelled in English but failed math classes. I always had to give myself extra time to find my way as I constantly got lost. In fact, my son recalls how excited he was when I acquired a GPS because it saves us both so much time in the car. I could not read maps or understand graphs at all. I remember I was so ashamed about my illegible handwriting, my poor math skills, and terrible paper management. Now I use a lot of accommodations, including the computer, which is awesome for me, and the GPS, and an assistant. And I believe in sharing this with my patients as a model of how you can adjust, compensate, and thrive when you have a learning disorder. Okay, so what's the negative impact of all these disorders? And I have already referred to some of this. So people with ADHD suffer because they're very disorganized. They're seen as very flaky, and this really impacts them socially, academically, and professionally. So we talked about people with ASD have real trouble making friends. They're often very concrete, so they have real trouble making associations and understanding concepts at a high level. People with language-based LD have trouble socializing academically and professionally. And people with MVLD, interestingly enough, they have trouble doing tasks that require sequencing. So even like toothbrushing, taking a shower, cleaning their room is so hard for them because it entails a sequence of motor activities. So sometimes it's interesting, I had a patient who really struggled with her hygiene, and she was a very verbal, articulate, very empathetic individual. And so her psychiatrist decided that she was severely depressed, and that's why she wasn't able to shower. And that wasn't the case. She wasn't able to shower because she had a nonverbal learning disorder, and there was too many steps. So we really worked hard on just kind of organizing her and making sure that she put all of her, what she needed in the bathroom and so on and so forth. And she got better. She still doesn't shower 100%, but she definitely got better. Helping them organize is really a big part of it. Now, in terms of working analytically with these patients, the most important piece of this is the emotional impact. So one thing that I kind of referenced earlier, and I will kind of reinforce, is that the experiences in childhood are extremely painful, and in fact, they're kind of like traumatic. Sometimes the patients have pretty significant PTSD symptoms, particularly if they've been physically or emotionally abused or verbally abused because they weren't able to perform according to expectations, either academically or socially. The other piece of it is that they are repeatedly exposed to experiences of failure, and that sets up a lot of psychiatric issues that I'm going to address. One big one is that they feel very badly about themselves, and it's very difficult to shake. I have some patients who I've been working with for 4 or 5 years, and they still have terrible self-esteem, terrible self-loathing. And the berating is a very particular type, because a lot of times with people with these type of challenges, they present as being able to do it. They don't have, they're not in a wheelchair. They don't have anything visibly wrong with them. So everybody is like, well, why can't you do that? You must be joking, or you must be obnoxious. And so as a result, anxiety and depression set in, and they often are lifelong companions. And when you can get a kid when they're younger, it can be life-saving. But even if we get somebody when they're older, just to explain what happened and let them have compassion for themselves as a kid is very crucial. Now I'm going to go over the psychiatric sequelae of these patients. I already talked about depression. I want to talk about the imposter syndrome because that's a really important one that comes up a lot. So many times these patients will tell me that they feel like a fraud and that they've learned that they have to fake or lie or pretend. In fact, I just saw this kid yesterday who very, very clearly has undiagnosed ADD, and he told me that he has to pretend that he knows all the Spanish, but meanwhile, he doesn't know any of the Spanish because there's an expectation that you should know this. I had a kid who was going to law school, and he told me, Dr. Sorscher, I have never finished a book in my life. I don't know, I've always just pretended. I've always just read the Spark Notes. I'm like, okay, that's because you had dyslexia. So the imposter syndrome really comes up and really needs to be unpacked. Learned helplessness is another very important syndrome. Now, learned helplessness is a concept that we know because we did a lot of studies on rats and dogs and I think even cats or different animals. And basically it's a situation where you expose the animal to a situation where they can't escape and they're being shocked repeatedly and there's no escape. Then you set it up where they're in a situation where they can escape, but they don't escape because they've already adapted the mentality that there's no escape from their situation. And that's exactly what happens with people with learning and attention issues. they're in a situation where they cannot escape. They cannot succeed. As much as they try, whatever they do, it doesn't work. So after a while, they completely give up. And even when you present them a path forward, they'll reject it because they know it's not going to work. So that is one of the big pieces also to work on, is helping them, empower them, and help them understand that, yes, you did fail because you didn't have support, but now you can have support and you can succeed. I also very often use the fight, flight, or freeze idea with my patients. Part of this is because I feel like there's a lot of trauma involved. So one of the responses to trauma is a fight, flight, or freeze. And again, this has been documented in animals, but also in people and even in kids. So let's say the child is in school and everybody else is doing their work, but the child doesn't know how to do the work. The child really has three choices. They can fight back. The teacher's mean, the work is too hard, everybody is against them. They can flight or avoid, put their head down on the table, just stop doing it. Or they can freeze in place, and you see that, the deer in the headlights, where they don't know what to do and they're completely frozen. And this happens as adults. This happens to them in social situations, or when the boss puts them on the spot, or when their mom asks them a question that they are worried that the person's going to be mad at them. So I work a lot on explaining these cycles and helping them through it. And it's also very helpful for them to understand that there's a reason why they're doing these things. And again, that comes back to how you work with them analytically and giving them insight. I also explain the anxiety avoidance cycle. I find like I have to do that a lot because it's much easier in some ways to say, I don't want to do something, instead of saying, I can't do it. Because I don't want to do something saves face. Saying I can't do it is very shameful. So I try to explain to them the anxiety avoidance cycle that you feel like it is you don't want to, but really it's more like you are convinced that you can't. And that if you felt like you could and you had the confidence, you could approach it. The last thing that I'm going to talk about here is the self-fulfilling cycle. And Charlie Brown talks about this, and he's afraid to be too happy because whenever he gets too happy, something bad happens. And these kids are really used to getting the rug pulled out from under them. Whether it's first they do well in school and then they go down a rapid slide because their work gets too hard, or whether it's first they're really good friends with somebody and then they inadvertently offend them, and then all of a sudden the person doesn't want to be friends with them anymore. So they're kind of used to things not going their way, and therefore they set it up for it not to go their way. They're accident prone, they're prone for misunderstandings and miscommunications, and a lot of work has to be done on helping set them up for success. One of the things that I recommend if your patient doesn't already have an assessment is to get an assessment. I'm going to talk about the very, very broad terms what an assessment entails and why I think it's so important. So basically an assessment is, for me, a very comprehensive assessment, which includes IQ, academic skills, attention, memory, language, motor, and personality. Now for personality, I'm a little old-fashioned, and I always give the Rorschach and the TAT, and sometimes there's pushback about that. I also give personality inventories. I do it all. But I like giving the Rorschach and the TAT because I like the flavor and the nuances and kind of getting more of a feeling for how the patient defenses are and how they are perceiving themselves and how they're perceiving other people, not so much on a superficial level, but also on a deep level. I think it's very important to get all the neurocognitive functions because, as I said, sometimes people could do great, let's say on the IQ, but then they fall apart on the attention, for example. So you really need to get all the pieces of the puzzle together before you make a diagnosis. There are lots of different ways to use the assessment, and sometimes it's just purely for the patient, to get the patient information and help the patient understand their learning style. Sometimes if it's a child, it could be for the school. Sometimes it's to give them recommendations for testing. So there's all different reasons why the assessment is useful. Even if you're 100% convinced, let's say, that your patient has ADD, your patient still might need an assessment for a variety of different reasons. Once your patient is diagnosed, once they get assessed, they have lots of opportunities for treatment and different types of treatment. I'm going to go over some of them, and I'm going to talk about how I do treatment, what I do. So there's psychoeducation, which is kind of what we've been talking about, educating the patient about their challenges, educating the school, educating even the people at work, educating their loved ones, so that they understand what's going on and that they can react to the person and give the person support in an appropriate way. There's psychoanalytic therapy, and as I said early on, these patients were not considered to be analytic candidates, but that's no longer the case. And there's a growing number of cases in the literature and theory about how to support and how to help these patients in terms of insight and in a psychoanalytic manner. Both DBT and CBT are used. Obviously, we talked about how these patients have anxiety, they have depression, they have low self-esteem, they have poor emotional regulation. Both DBT and CBT can help with those. I find group therapy a very effective means of intervention with these patients, both because they often have social issues and often because they often feel alone and misunderstood. I run 2 groups, one for college-age kids and one for adults. I used to run a lot of little kid groups, but they all grew up, so now they're college-age and adults. And they all have learning and attention, and some of them are on the spectrum. And we talk a lot about the impact of that and what it means, and they really are able to support each other. And the thing about it is that these patients often need a tremendous amount of support. It's not just a therapist, it's a tutor, it's an executive functioning coach, it's medication, it's extra time. So to have other people that really are able to say, hey, I know what that feels like, and sometimes it's great and sometimes it's not, is really important. Now, I often will take a very active role, particularly at the beginning of the treatment with my patients, and provide them both scaffolding and support. Now, scaffolding is a certain technique that you use in education where you provide the person with techniques. So if the person comes in and says, hey, I'm having real trouble doing my work, I might say, okay, take out your work, let's see what's going on. Oh, you have to come up with a topic sentence, let's do that, let's do a concluding sentence, let's do supporting sentences. So it's really giving them a lot of scaffolding and a lot of structure to help them with whatever problem they're coming in with. And with patients like this, being active is often very necessary because they come in completely overwhelmed, helpless, feeling very disempowered. I'm also very interested in correcting misconceptions, and as I said, this can take a long time. It's not like I just say to people, hey, you have ADD, and they're like, oh, okay, Dr. Sorscher, that's great, now I don't feel bad about myself anymore. It takes a really long time. I had this patient I was working with who has a nonverbal learning disorder, and she was highly intelligent, but she thought she was stupid because her father would always call her stupid. So I finally had to tell her that we're banning the word stupid from our sessions, because she calls herself stupid at least 20 times during the session. And after, I would say, at least, 6, 7, 8 years, she was able to finally say to me, I'm pretty smart. I just have a nonverbal learning disorder. I was like, yeah. And we would kind of joke around about how stupid wasn't a word to use anymore. So I think correcting misconceptions is a big one. Now, I do a combination of everything. Psychoeducation, insight-oriented therapy, scaffolding, and support. I want to give an example of that. So this is a 32-year-old woman that I was working with, and she has severe difficulty organizing her resume because she had held so many different jobs, and she was very anxious about re-entering the workforce. And this is also common with people with learning and attention issues, is they end up job hopping a lot, maybe even going to a whole bunch of different schools or colleges. She recounted her inability to focus on completing paperwork at home and found herself distracted and depressed. She felt like a bad girl who could not do her homework. When I suggested that we work on her resume together, a concrete offer of help, she visibly brightened. While listing her disparate jobs on paper, she lamented her lack of education and related anxiety and shame at the toll her attentional and psychiatric difficulties had taken on her career. After her resume took shape, she commented on how much easier it had been to work on it and left the office feeling energized. My concrete support paired with affirmative intervention around understanding her struggles led directly to her increased confidence. Several months later, she began working with a job consultant and eventually branched on her own, applying to jobs directly and landing a position as a sales manager. So when you offer concrete help to these patients, it helps them understand that you do see their struggles as legitimate. I don't expect them just to get over it and do it, which is kind of a lot of the attitude that they get. And I really help them understand that this is a neurocognitive piece. And I'm going to sit here and I'm going to roll up my sleeves and I'm going to kind of be there with you. Because they're too often told that their learning disabilities are on their mind and all they need to do is just buckle down and everything is fine. So when I explain that, no, this is neurocognitive and we're going to come up with some strategies, that really helps calm them down. In addition to the neurocognitive struggles, these individuals may struggle to acknowledge their feelings, both to themselves and to others. They're getting paralyzing anxiety and tremendous feelings of depression. So my offer of hope and assistance helps combat some of that emptiness and some of those feelings of being alone that I think is really crucial in terms of these type of cases. One other thing that I do with my patients is that I really talk about their superpowers. And I do this both when I give feedback for the testing and while I'm working with them. And I really want to emphasize that I think leaning into the positive side of having neurocognitive challenges can be really great, as I said, for kids who are 5 up to people who are 75. So with ADD people, I focus on their high energy, their creativity, the fact that they can be very entrepreneurial. And I mentioned some famous people have ADD sometimes, or they'll bring them in. And Bill Gates is a good example of that. With the people with ASD, as I talked about before, they have a lot of passion. They can garner a tremendous amount of facts. They have an obsessive interest. And Greta Thunberg is a good example of that, where she really was able to marshal all of her attention to detail and creative way of thinking into really being a climate change activist. For the people with NVLD, they often are extremely talented with words, and I really will help them maybe develop themselves as writers or just reinforce that this is a really big area of strength for them. The language-based LD people usually have good visual skills, so I will talk about that. What's interesting is that people with dyslexia, because they see things in a different way, can be very creative and innovative, and a lot of artists have dyslexia. Dyslexic people in general are quite artistic, and I mentioned Picasso as somebody who used the way he saw the world in a very interesting way. So I think it's really, really important to help the patients lean into what's positive about their challenges and even using the neuropsych reports in that way, because the neuropsych reports always detail areas of strength and areas of challenge. And when I write the reports, I'm always writing like, well, they have this problem, and then I'll put in something positive, because I think, even when you're reading it, you can't just read a whole list of problems. It's too overwhelming. So I'm very careful to always put in a positive piece. And it's easy because part of what makes it a learning disorder is that there are areas of strength and areas of challenge. So there always are really good areas of strength. I'm going to talk about some accommodations and modifications. I had referenced some of them earlier as well. And these are things that you can recommend to your patients. And there are many other accommodations and modifications. So basically what I explain to my patients is you can either tweak the person or tweak the environment. So tweaking the person is, let's say, therapy, medication, tutoring, so on and so forth. Tweaking the environment is, let's say, extra time, curriculum modification, and so on. People with ADD, executive coaching is a really big thing right now, and I think it's very good for them. Really helps them organize, plan their time, figure out how to do things. Extra time, as I said, is a very important recommendation, both in terms of standard testing and also in terms of even doing any kind of work, even on a job. For people with ASD, it's good for them to put themselves in a low stimulus environment, and if they do have to be in a high stimulus environment, to give themselves breaks, sensory breaks. They are good with detail-oriented work, as I said, because it can be very calming for them. People with NVLD also need coaching. They can use executive coaching because they are very disorganized. They can also use social coaching because they have a hard time picking up on cues. And they often will do things that are inappropriate and they don't realize that. So a social coach or job coach can really help them both in terms of their ability to perform to expectations on the work side, but also on the social side. And with people with language-based LD, I do a lot of role play and try to really help them express themselves and have it much more automatic. Because the problem is that they do understand everything, but their fluency is impaired because their word retrieval is jumbled. So if we make it much more automatic and we keep on practicing it, they'll be able to be much smoother. I have a young adult with a language-based LD in my group, and we would practice together in the group, role play him, let's say, offering to take a girl out, because he would always get very shy about that, but also he just couldn't get the words out. So after a while, that became much more automatic for him, and he was able to ask somebody out, and actually now has a girlfriend, which is fantastic. So last but not least, I wanted to say that this was just a kind of a brief overview, and I try to both illustrate some breadth and some depth, but I have a book coming out that you can pre-order, and the book is exactly this talk. It's on neurodivergent children, adolescents, and adults, and it talks about all the things that I'm talking about, plus more, different types of learning disorders, literature, and then case histories and treatment. So I will now turn it back to Lisa. I'm going to stop sharing.
And so we're going to open this up to, hold on a second. There. And we're going to open this up to questions. That I didn't want to do. Sorry about that. I'm playing a little bit to get this right. And where is my... So I think if you can hear me, yeah. If anyone has any questions for Dr. Sorscher, please put it in the Q&A, and then we will address it as we go. Having a little trouble with figuring out. Okay, so are there any questions for Dr. Sorscher? So I have a question, and I just want to say thank you for a wonderful talk. I am familiar with some of this material because we worked together on the book, and I can share with the audience that I'm a clinical psychologist, I'm not a neuropsychologist, but it's really helped my treatment of a general population because this stuff just comes up all the time. So do you have any thoughts about how to work with these issues with patients of different socioeconomic backgrounds? Because you mentioned a lot of patients who are in graduate school. And how about patients who come from less advantaged backgrounds? How would you address these issues?
Here's a good question. I think, and starting with when patients are younger, right? It's really very important to diagnose them correctly. And sometimes people from lower socioeconomic class, they either get overdiagnosed or underdiagnosed. In fact, learning disorders and attention disorders are somewhat overdiagnosed, and ASD, interestingly enough, is underdiagnosed. So one thing I would say is very important is for the psychologist to be very aware, and also culturally, parents might present, like for example, lower socioeconomic class boys who have ADD are often seen as oppositional, troublesome. They want to shunt them into special education. And that's been a very big issue. It's been discussed a lot. And, you know, for me, when somebody comes in who is from a lower socioeconomic class and says that they're having trouble with their kid behaving, I think right away, oh, is this ADD? And could this be then misdiagnosed as oppositional defiant disorder, which a lot of these kids are, and they don't have that. You know, they might develop it because of the way they're being treated, but they don't have that. I'll also say that we live in New York City and there's a tremendous amount of resources. And I get, referrals every single day for people who cannot afford private services. And I always recommend the William Alanson White Institute, which is a great place. Delphi University has a fantastic clinic. NYU Postdoc has a really good clinic. So there's a lot of, and Columbia actually gives free therapy services. And there's a lot of services that you can direct people to with sophisticated clinicians who will really give them good treatment. And if you're aware of those services, which, I am, I love actually recommending them. And I feel like I can really save people's lives, because if they get into bad treatment or no treatment, they really go downhill. And part of that is because of the either under or overdiagnosed, like maybe overdiagnosed even as bipolar or schizophrenia, by the way, instead of ADD or language-based LD or autism. There's been a lot of good research on that now.
So we have some questions in the Q&A. And the first one is, can you speak to how you help patients understand their child's developmental disabilities and advocate appropriately?
That's a really good question. It's a lot of the work that I do. So one thing I do is I'm very empathetic with the parent. And you have to understand when the parent comes in and you're telling them your kid has a developmental disorder, your kid has a learning disorder, whatever it may be, it's very bad news for them. And there is a very big period of grief and loss, because they've lost a child that they hoped they would have, and now they have a different child that they need to take care of. So one thing I do is just be very empathetic. Another thing I do is say that there's a lot of resources out there for the parents. I really believe in the support groups for the parents, and ADD has a wonderful parent, activism chapter. ASD actually has that as well. LD is not as good, but, giving them resources. And the other thing that happens with the parents is that they feel very guilty and ashamed, because often they've been pretty harsh with their kids and saying kind of not great things about their kids because their kids have these issues. And then when they realize that, they express a lot of shame and a lot of guilt. And anyways, parents will always feel guilty. So it's very important to reassure them and say, look, you didn't know, now you know, this is a way forward. And as I said, it often can be a process because parents come in on different levels, and often there's a split in the family. Let's say the mom is like, okay, this kid is ADD, I want the kid on medication. And the dad is, no, that kid's just like me, he's fine. You medicate him over my dead body. So there's a lot of mediation also within the family, and getting a lot of education, and kind of explaining that this is really a journey, and that your kids' needs are going to evolve. And even though the kid looks like this when they're 4, they could be very different when they're 8, and then even more different when they're 12. And the most important thing is to say, I'm in this with you. I'm going to hold your hand through the process. I don't believe in just giving the parent a report and saying goodbye. Like that, I think is really unhelpful and very overwhelming. I'm like, don't worry, don't even read the report. This is just what you need. Take it easy, step by step. I'm going to get you the resources, and we'll do it together. And if you cannot do it with the parent, to find somebody who can help them negotiate that.
So the next, this is from an anonymous attendee. Thanks for your talk. Do you know of resources for low cost or Medicaid neuropsychological assessment?
Yes. So as I said, William Alanson White, all the major hospitals do neuropsych assessments. That's for Medicaid. There is, I'm trying to think. So Delphi University, probably most of the universities, I just know that Delphi does it because I went to a Delphi, and William Alanson White I know because I supervise there. But there's another place, I'm trying to remember what it is now. I think it's Greenwich House. There's one of these places that does pretty good services, but I always steer the patients to the institutes, because I feel like even though there are students who do the evaluation, they're very well supervised, and they give them a ton of time and a ton of attention, and it's kind of like an undersung resource.
I believe we also provide these evaluations at the Mount Sinai Behavioral Health Center.
Oh, no, absolutely. All the major hospitals, Columbia, I worked as a psychologist, Columbia Presbyterian. We did them excellently, actually. I'm sure Bethesda does a really great job. Like the major hospitals are a very good place. The only thing with them is that it's very bureaucratic and it could be hard to negotiate. But again, you can empower the person to just be like, this is what my kid needs, and they'll get it. They just need to really stick to it.
Okay, and then we have a question from Dr. Cynthia Green. Thank you for an interesting presentation. Do you have anything to share about these issues and older adults and any particular challenges?
That's a really good question. And I was actually just reading in the Times that there are some people who, after they retire, they get diagnosed with ADD because their job really held them together. The job was like medicine. And I actually recently saw a guy like this. He was a CEO of a big company, running around, doing a million things, retired, cannot get anything done, super depressed. I was like, oh, it sounds like you have ADD. And oh, no, I don't have ADD. And we talk about it, and he starts telling me how he always got in trouble in school, and he was a late bloomer, and he had trouble going to college, so on and so forth. It's really important to be mindful that these issues can crop up at any time. With this particular person, I did recommend medication, which is something to recommend. You have to be careful, especially with older people, if they're taking other medications that will interfere, but that was very helpful for this person. Sometimes I recommend coaching. Sometimes I recommend just putting some more structure and support in their day.
Okay, and then another comment from an anonymous attendee. Thank you for your talk. You've described an eclectic approach for treatment with neurodivergent individuals. Could you elaborate on how you incorporate psychodynamic intervention in particular?
Sure. So there are certain psychodynamic concepts that I'm very tuned into. For example, feelings of shame. And I work with them in a very particular way. I'm also very tuned into transferential and countertransferential enactments and pieces. And I think these patients are actually, I mean, you know, that can happen with any patient, but with these patients, it can be particularly intense because I find myself maybe having, sorry, let's wait for the siren. I find myself maybe having feelings of frustration. And also when there's shame in the room, the shame is like a hot potato. It gets passed from, you know, one to the other. I'll give an example of a patient I was working with, and she was struggling with getting into graduate school. So I said to her, you know, I was encouraging her, and I told her, you know, I also had applied to get into graduate school a couple of times before I got in. And she turned around and she told me, oh, but that's because you were really stupid because you have a learning disability. So I had to then calm myself down, take a deep breath and say, oh, that's very interesting. What makes you think that people are stupid if they have learning disabilities? And then we were off to the races. So I would say really focusing on the feelings of shame, guilt, the self-esteem, and looking particularly about how that plays out in the transference and the countertransference is the way I work with these patients analytically, and understanding that there's a contribution of their learning and attention issues, or whatever is going on neurocognitively, but then there's the piece of the relationship that's really important.
Okay, so we have another couple minutes. If anybody else has any questions. Well, I'll bring up another, okay, we have a raised hand from Dr. David Dorfman. And let me find you and allow to talk. Okay, hold on. Okay, so you can talk, David. Do you want to unmute yourself?
Yeah,
there we go.
Can you hear me now?
Yes.
I hit the wrong button. I didn't have a question. I'm embarrassed.
Nice to hear your voice.
Okay, so I'll mute you again. So I will ask a question then. Just lost track. How do you think about medication with a lot of these patients, particularly ADD medication? How do you work with that?
That's a really good question, because I think it does factor into the treatment. And part of what I do is I really work as a quarterback. because a lot of the patients have not just medication, right? They have a tutor, they have an executive functioning coach, they have a social skills coach, they have a job coach. They have a lot of people. There's a lot of people in the mix. And it's not just taking medication, they have a psychiatrist. So they need a quarterback. They need somebody who's going to help them organize and integrate the treatment. Otherwise, it's completely split and they tell one person one thing and the other person the other thing and me something else, and it all kind of just goes into the soup. So one thing I do is I really collaborate and have a team approach with the people working. I'm also very mindful that the medication has its own transferential aspects, and the patient could feel really good about the medication. The patient could feel really terrible about the medication. I've had patients, particularly with ADD meds, where they feel like they're in a straitjacket and they feel very depressed and sedated, or they feel very loopy, but they feel like they need to take it because it helps them focus and do their work. So there's a lot of work that I do in helping them advocate for themselves with a psychiatrist and say, hey, look, this is helping me focus, but I have all these, side effects. And I think a lot of the work with being with a patient who's on medication, and most of my patients take a cocktail of medications, is being very aware of what that means to them on the psychological level, and also helping them advocate for themselves and whatever is going on, because there could be pretty debilitating side effects that they're just gonna kind of be scared of touching because they're so happy with finally being able to focus or not feel depressed or whatever the case may be.
Do you have patients who don't want to take medication because of the stigma of it, as we often see with psychiatric patients?
Yeah, it's interesting. I would say that 30 years ago, if I would tell somebody that they had ADD or their kids had ADD, they acted like I was sending them to, the electric fence or something. And now I have kids who come in and say, hey, I have ADD and I want meds. And there's been such a huge shift in the culture that I would say, not that there's no stigma, but there's almost a cachet. And even in being neurodivergent, I'll have kids come in and they'll say, Dr. Sorscher, I have autism. I'll be like, really? You have autism? And sometimes they're right, sometimes they're wrong. But the fact that they're thinking about it, and the fact that they're diagnosing it, not only in themselves, but in their peers and their family members, the whole culture has done such a shift. And I actually think in general it's a good thing. I think it could be a little bit much, but I think in general it's very helpful, because I no longer have to struggle to say, it would really be good if the person could have some medication or extra time or whatever it may be. In fact, sometimes it's the opposite. They want all these things, and sometimes they don't meet criteria for that. So it's almost like an opposite situation now.
So we had someone who raised her hand, but she has dropped off, so that may have been another mistake. So we are coming to the end now. And I want to thank Dr. Sorscher so much for joining us and sharing her many years of experience and expertise with us. And so that will be it. And as Dr. Palmisi had said, we are going to break for the summer, and we will be starting the psychology grand rounds again in September. So I want to wish everybody a great summer. And again, thank Dr. Sorscher.
Thank you so much, Lisa.
Bye.
Bye-bye.